I'm Dimitrios Stefanidis and will be discussing with you today coaching and telementoring in surgery. And I greatly appreciate the opportunity by Sages to present this to you. I don't have any disclosures. I think we all know that the goal of training is to take a novice and make them an expert in surgery. Specifically, this is the Dreyfus model of skill acquisition. And this happens typically with experience that we accumulate during residency training, fellowship, and then later in practice. However, we also know that experience alone is not adequate to get us to the level of an expert. According to Anders Ericsson, what is really needed is deliberate practice. And deliberate practice means we push our performance beyond our own comfort. We set specific goals. We focus on repetitive practice activities. We receive high quality feedback and develop eventually the mental model of expertise. A key component of deliberate practice is the high quality feedback. So we should ask ourselves, what is the performance feedback we receive currently in surgery? For residents, we clearly provide feedback to them. However, the literature suggests that that feedback may not be as good as it should. Many residents perceive that they don't receive adequate feedback. On the other hand, for practicing surgeons, there's a huge gap that exists, given that most of them don't really have access to feedback. The absence of that feedback could be one of the main drivers for the existent variability in surgeon outcomes that is well known and described in the literature, as in the study by Birkmeyer. So clearly there's a need that surgeons have for reliable feedback mechanism that allows us to continue improving our performance, both during as well as after training, and more reliably achieve the level of expertise that we all want to get to. One of the challenges is obviously, how do we provide such feedback to everyone? Clearly, most of the feedback is best delivered in person. However, it's not always feasible. Low resource settings may make this impossible. Remote locations or situations like the current one we're living in, where we are quarantining or isolating, which does not allow in-person contacts. So that's what brings us to coaching and telementoring, which are solutions that address those two challenges. So coaching is defined by the International Coaching Federation as providing objective and constructive feedback to help a coachee recognize what works and what can be improved. Telementoring is a relationship facilitated by telecommunication technology in which an expert, the mentor, provides guidance to a less experienced learner, the mentee, from a remote location. Clearly, there's some blurring of the lines between what's coaching and what's mentoring. And oftentimes, the two terms are used interchangeably and in a confusing manner. An easy way, perhaps, to think about this is that a mentor, similar to the relationship between Telemachus and mentor, is a more experienced, wiser individual, a surgeon, potentially, who can share his or her experience with a less experienced colleague. It's a longer-term relationship. It's not necessarily always structured, and helps in maturing the younger colleague. The mentor may not have expertise in the area of the mentee. However, they have a general understanding of the field. In contrast, the coach is specifically trained to bring the performance of the coachee to a specific level. They have a task they accomplish, and once that task is accomplished, they typically move on. They're masters in they have mastered, however, the process of coaching. They have specialized training. So is coaching effective? There's a number of studies that demonstrate, this is a systematic review that's shown that coaching is the most effective method to transfer the teaching to the learners. As you can see in the left graph, 95% effective compared to other methods of teaching and instruction. And in regards to implementation rate, refers to the learner actually implementing what they were taught into their practice. Coaching achieves about 75% of that versus other professional development methods that fail actually in the majority of cases to do so. So in surgical training, a systematic review that looked at 24 randomized controlled trials comparing about 400 residents that had video-based coaching versus another 400 that didn't, and used OSATs. Most of them used OSATs to assess performance and provided the video coaching either before or after surgery. You can see that the forest plot that compared all the studies was clearly in favor of video-based coaching with significant benefits in favor of those who trained versus those who received traditional teaching. And in the sub-analysis, actually, both medical students saw improvements, but residents actually saw bigger improvements, and those improvements were especially pronounced for operating room coaching for operative procedures. For surgeons in practice, another systematic review looked at 26 articles that described coaching programs for practicing surgeons. So most of them focused on teaching new skills, but some of them also focused on refining skills. Of those that reported the outcomes of coaching, in 42 to 100% of participants reported that they changed their clinical practice directly as a result of the coaching they received. And the satisfaction with the coaching they received was very high, 82 to 100%, which is really telling. Tele-Mentoring, a systematic review of the literature, 66 articles, suggested that pretty much all of them are done with using a combination of audio and video. 60% implement screen notation, either telestration, where the mentor draws on the screen of the mentee, or image overlay, where they impose an image over what the mentee is seeing. And actually, in a few cases, 23% of the studies also use mental control, either of the camera or systems of energy, usually using a robotic system that enables that. Different bandwidth speeds were used, and latency varied significantly among the studies, and the cost was also fairly significant for the initial setup as well as the maintenance cost afterwards. The effectiveness of telementoring, when in studies that compare telementoring versus in-person mentoring, about 60% did not find any significant differences in outcomes. A third of them found that telementoring may not have been as good as in-person mentoring, while a few found actually was superior. Importantly, was that there were no differences in outcomes, in clinical outcomes of patients, whether one or the other modality was used. And in studies that compared telementoring with no mentoring, like self-practice, for example, for FLS, the majority showed a significant benefit to telementoring. So for FLS in specific, performance was better with telementoring, and 100% of telementored surgeons achieved FLS certification compared to only 40% in the self-practice group. So how to do this? Typically, coaching is delivered in a reflective rather than directive manner. And the purpose of it is to invoke on the coachee analysis, reflection, and action. A great model is the GROW model. You can find a book by Alan Fine that describes it very nicely. It essentially sets a goal, checks the reality where somebody is at the present time, and then identifies the different options that will help them move forward and achieve the goals set. We have previously published a model where we essentially video recorded procedures, reviewed them, identified areas for improvement, provided that feedback in group as well as individual coaching sessions, then used simulation for deliberate practice with feedback and coaching, and then monitor patient outcomes and close the loop again with repeat assessments. The Wisconsin Coaching Framework is a great model that has also published a lot of positive results. It includes similar activities as are shown in the image here, setting goals, motivating, encouraging the participants, and developing and guiding them, creating a model, and setting coaching both interpersonal skills as well as using different versions, different ways of coaching, peer versus expert, video, live, etc. There are a number of challenges. Cost is a challenge, resource intensive, both approaches. There's a surgical culture that often perceives a lack for the need of coaching. We're already good, we don't need anything. There are legal issues with discoverability. And Tele-Mentoring has special challenges like the internet availability has to be there, transmission latency should be not too long because otherwise it's very hard to do it. The bandwidth is important, cybersecurity, HIPAA compliance, etc. So in conclusion, coaching is paramount for the continued improvement of surgeons, technical skills and beyond. Tele-Mentoring provides the opportunity to effectively reach and train surgeons across the globe and in remote locations. Both approaches have been shown effective for performance improvement. You should become familiar with these approaches because while there are a number of barriers currently, I do believe that these education modalities will shape the training of our surgeons in the near future and will help us get our performance to the next level. As Tom Landry said, a coach is someone who tells you what you don't want to hear, who has you see what you don't want to see, so you can be who you have always known you could be. Thank you for listening, and I hope you enjoyed this presentation.